All right. Okay. So good morning again, everyone. Welcome to today's class. And today we're talking about a cesarean session. It's just a minute. All right. Apologies about that. So today we're talking about cesarean section. We have none other than consultant OBGYN, Dr. Olajuwon Alabi, who is also the medical director of South Shore Women's and Children's Hospital. We've had him for the session on miscarriage recently, and mamas. I mean, we had such great feedback from you. Dr. Alabi is definitely one of the best in the country. We can say that confidently, and to have him here is such a huge privilege. Dr. Alabi, good morning, sir. How are you doing today?
Good morning. Do I need to put the video on or not necessary?
I mean, it's always nice to see the face of the speaker, but if it's going to be too much.
I was following the room because you didn't put yours on, so I was copying
Okay. Okay, I just got in. I guess I'll turn my on soon, but it's okay if you are not able to put it on as well.
Okay, all right, no problem.
All right, then. Thank you, sir. All right. So just to get right into this is CS of a thing. The first question I'm gonna ask is, when it comes to delivery options, vaginal delivery, CS, there's such a huge stigma. Oh my gosh, such a huge stigma and fear that comes with having a CS for moms. The moment they are told they're gonna have a CS, a lot of them are already worried. Oh my gosh, what does this mean? I was wondering if you could just start by telling us what are some of the indications that a mom needs to have a cesarean section.
Okay, can you hear me clearly?
Yes, we can hear you very well.
Okay, so I think there are, let's see, how many people in the room? Now, there are 18 of us in the room. I want to say thank you for everybody for coming to listen. And I sincerely hope that whatever I talk about will have some kind of impact on some of you in your decision making. I think you're absolutely right. I think especially in the African community, I mean, okay, let me limit it to, let's say the Nigerian community. I'll give you an instance. I was running a labor ward in a BCG hospital in Leeds a few years ago, and I met a Nigerian who baby was obviously distressed, and I said, you know what, we need to go for a cesarean section right now. And she said, no, 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 doctor, I can't. I need to call my pastor first. And I'm looking at the baby is very distressed, and you're telling me you want to call your pastor. I think in as much as we're very religious in this part of the world, but I think some decisions are just for safety reasons. Okay. So, but I understand the fear sometimes because, back at home or in Nigeria, there's a lot of bad outcome with deliveries, and sometimes it's very difficult to know the reason. Sometimes it's a carelessness on the part of the patients. Sometimes it's carelessness on the part of the hospital they went to. Sometimes, so I think that makes people worry about making that decision. Now, coming back to your question, which is what are the indications? Indication varies so I think there are two categories of cesarean. There's the emergency one, and then there's the planned one. So I think this morning we're talking more about the planned cesarean section. So why would I have a reason to plan my cesarean section and say, oh, I want a cesarean section? Believe it or not, a lot of people actually just want a cesarean section, which is something we call maternal choice. They have looked at their risk. They have a very serious phobia to have a vaginal delivery. Some people are not. They probably watch delivery on the TV and see people screaming and shouting, or they visited somebody in the hospital. They've seen that sometimes you can have vaginal delivery and then you have different kind of tears down there. Some people also believe that if I have a vaginal delivery, my sex life with my husband is not going to be the same again. So some people will just come into the hospital and say, I want a cesarean. Also, let me roll back a bit. If you go into labor, you're not guaranteed a vaginal delivery. So you might go into labor believing that you're going to have a vaginal delivery, but for different reasons. you might end up having an emergency cesarean. So some people will weigh their option and say, okay, emergency cesarean, vaginal delivery that I can't guarantee, that might end up with issues. Should I just have a planned cesarean where everybody's calm, you can play reggae music, you can play apala, you can play anything you want. And it's such a calm situation and stuff like that. So some people elect to do that. Okay, so what are the reasons? What are the other reasons apart from maternal choice? Let's look at baby. So let's look at, we're going to categorize it. For every delivery, there are three factors. There's the baby factor, there is the womb factor, and then there's the mother factor, which can also be womb factor, but we'll separate them: mother factor, baby factor, and womb factor. So let's go back to, let's do womb factor quickly, because it's a very common thing in Nigeria to have fibroids and also to have had a fibroid surgery. So let's look at, you had a fibroid surgery a few years ago. Okay, I like to give example. So I got a desperate call from one of our ex or former clients in South Shore who is now in the UK, and sent me a message very urgently yesterday and said, Dr. Alabi, you operated on my wife about 4 years ago, and she's in labor in a UK hospital, and they want to know whether to let her have a vaginal delivery or not. So my first question with him is that, why are you waiting to labor when she's in labor to be finding out this information, which is not necessarily his fault? Maybe the doctor looking after him, they should have done a bit of, oh, you have fibroid surgery. Let's get a lot of information from that. Anyway, so I was quite busy, but I did manage to get his wife operation notes. And we removed about 22 fibroids at that time. So it means that that womb has different scars on it, different position and scars. The good thing is that she got pregnant after the surgery. So that removed, oh, you can't get pregnant after fibroid surgery. Anyway, rightly so, he told me a few hours later that, oh, doctor, thank you very much. My wife has had a successful CS, everything went well. So previous surgery, let's say you've done a fibroid surgery or you've done a previous cesarean section before, that almost puts you in the bracket of having vaginal delivery. I'll come back to the cesarean section because I need to explain that. If you've had more than one cesarean section, automatically, if you go to any hospital, they're going to offer you a planned cesarean section if you've had more than one cesarean section, because now the reason being that your womb so when they cut your womb and it heals, it's fine, it heals, but that's a potential scar area, which you can't really explain whether subsequently, if somebody's in labor, that area can open up by itself and lead to something called uterine rupture. So to prevent that from happening and to prevent that from happening in labor, your doctor should offer you a cesarean section. Now, if you've had one cesarean section, the reason for when you come to the hospital with your next pregnancy, decisions will be made between you and your doctor about what was the reason you had that first cesarean section. There's something we call recurrent reason. There's something that are non-recurrent. For example, if you had the cesarean section because of the position of your baby, let's say your baby was coming leg first or hand first, then they decided that it's safe for us to do a cesarean. Your next pregnancy, if your baby is coming head first and everything is perfect, there's no reason why they can't allow you to do something called VBAC, which is vaginal birth after cesarean section. So we've talked about the uterus. So the uterus can be a scar on it. Scar can be, oh, I've had a few cesarean, or I've had mammectomy, or I've had some kind of issues with my womb. So that will automatically, they'll offer you cesarean section. Now let's go to baby. There are different reasons why baby can, go back to the womb. So I will categorize the placenta, which is, I'm sure everybody knows what the placenta is. The placenta is the part of the pregnancy where the baby and the mom meets. So the baby has this big round thing that attaches to the inside of the womb. And then that allows a connection between the womb and the baby for feeding, for blood supply and stuff like that. So during implantation means the egg has been fertilized and it needs to attach to the womb. Sometimes it can attach on the lower part of the womb, so something we call placenta previa. So it attaches there and cover the exits of the womb. So when it covers the exits of the womb, it means that the baby is there fine, but the placenta is covering the entrance or exit to the womb. So it can't go out unless that placenta comes out of the way. Now, if you think about it, this is the placenta that feeds the baby. If a woman is in labor and you need to get the placenta out before the baby, I mean, I'm sure everybody knows that's quite dangerous because it means that that placenta will bleed, or if it detaches from the womb, obviously the baby will be compromised, which will probably lead to the death of that baby. So any low-lying placenta, if they tell you that you have a low-lying placenta, then your doctors are likely to offer you a planned cesarean section. Now, still on the baby, like I explained earlier, if the baby is breech or any other presentation apart from head, your doctor will tell you that they need to do a cesarean. Having said that, for the most common one, which is breech, in some part of the world, there's something called external cephalic version, where the baby can be turned from breech to head. That is not very common in Nigeria, and I think maybe rightly so, because Nigeria is a very unique country where so in the UK or America, if you turn a baby, everybody understands that there's a risk associated with that. If you turn a baby in Nigeria and something goes wrong, I'm sure that the police can come and arrest you for murder the next day. So the question is that why do I need to put myself through that? So a lot of the breach in Nigeria, I don't even think there's anybody that does, not that they can't do it. I don't think there's anybody that venture into cephalic version in Nigeria. I mean, they might do in the public hospital, but in the private sector, nobody does it. So that's presentation, meaning the position of the baby. Sometimes the size of the baby as well. Some babies are very big, massive babies. We call big babies any baby above 4 kilograms, and some babies are very small. Now, if your baby is very big and the woman herself is very small, your doctor might tell you that, oh, the likelihood of this baby coming out is very slim. I think we should go and do cesarean section. Now, having said that, that's a relative indication. What I mean is that it's not absolute, because you can have a small woman and a big baby and she pushes the baby out easily. But I think it's like mitigating risk, looking at the risk factors and trying to prevent what will happen from that. So your doctor might tell you that your baby is big. I think it's safer to do cesarean section. I think obviously that's a communication between you and your doctor. The second thing is a very small baby. Now, average baby is about 3.5, 3.7, 3.8. Let's say you're about 39 weeks or 38 weeks and your baby is measuring less than 2.5. Your doctor can tell you that I think it's safer to do a cesarean section. That's a relative risk as well, because the reason they offer you that is that labor itself is very stressful. And if a person is in labor, the labor can stress the baby out. I mean, if it stresses the baby out, the baby can eventually start having lack of oxygen and then leads to maybe an emergent section of problem. So to avoid that, the doctor might say, you know what, let's do a cesarean section. So there are other indications apart from all the ones I mentioned. Sometimes people just have difficult pregnancy, something like preeclampsia. You come into the hospital, your blood pressure is extremely high, you have a lot of protein in your urine. The doctor is looking at how quickly well, that's almost relatively emergency cesarean, but sometimes it's still planned. So it's almost like a semi-planned cesarean. I think I've mentioned most of it, which is baby, mom, and sometimes as well, some babies have some congenital abnormality and it's not safe for them to go through labor. So maybe the pediatric, okay, so some babies that are born with deformity that can be operated on, they might want to do an elective cesarean section so that once the baby is born, the baby is handed over to the pediatrician. So they don't want the labor to stress the baby out so that the baby is in good form to go through its own treatment. So I think I've mentioned most of the indication. I mean, there are other indications, but those are the common ones. Okay?
All right. Thank you very much, sir. I'm sure that we'll just take when we're almost done, we'll just take a few questions and scenarios from the moms. But I want to talk about planning, what moms should do when they are going to what they should do when they are preparing for a planned CS. So they're already aware that due to the presenting conditions, they should
Yes.
have a CS. Now, a lot of moms worry, oh, some people say, oh, should I eat? Should I not eat? What should I know? In terms
Yeah.
of planning, because we'll
Yeah.
still talk about during the process what they should expect. But in terms of
Yes.
planning, what should they know, sir?
Okay, so the first thing is, so you've had a decision with your doctor. Okay, your doctor says, oh, I'm booking you for a cesarean in 2 weeks' time. So the first duty of the doctor is to make sure that you are safe for that cesarean section. So he wants to check you and make sure, do you have diabetes? Do you have hypertension? Do we need to correct any issue? Are you anemic? Do we need to give you iron medication? Do we need to do all that? So they must be able to sort out any pre-existing condition. The next thing is a midwife or a nurse coming to you and say, okay, these are the needs for you during your admission for the cesarean. So things like your bathrobe, your towel, the baby needs, because there's always a list, and I guess you are familiar with that. So there's a baby list and there's a mom list. So please get all this ready. I mean, what we usually encourage our women to do is make sure they've sorted out their bag or their suitcase or whatever they're bringing in before 36 weeks. Now, I must say that something I haven't said is that in all over the world, most people like doing their cesarean after 39 weeks. I know that in Nigeria, everything goes, but in most countries, they will not do a planned cesarean until you're about 39 weeks, unless there's a mitigating factor that prevents you from. The whole idea is that to make sure that the baby's lung are fully developed and you don't have to admit the baby into neonatal intensive care after that. So like I said, so you will get the list ready. They will do something called preoperative assessment, take your blood, in cases where there's a potential risk of bleeding, they will take blood and get blood ready, something called cross-matching, get the blood ready. And then somebody will tell you, so every hospital is different in their admission process. Some hospital will admit you a night before the surgery. Most modern hospital will admit you on the day of the surgery. But also, it depends on who you are as well. If you're a very anxious person or you live very far from your hospital, you might want to stay a night before. So you're used to the environment, and then you can, since you're sleeping in the room that you're going to do the section on, it's very easy. Obviously one of the things you need to think about is that any hospital is like a hotel. If you stay there more than you will pay for the room, so you need to think about that as well. Now, so after doing that, they give you a date. Obviously, during the pre-op assessment, they would have talked to you about what kind of anesthesia you're having. Nowadays, it's almost, I mean, I can tell you that I haven't done a cesarean section with a patient sleeping for a few years because we can use something called spinal anesthesia, that injection in the back. And contrary to what people think, it's a very safe technique and is used very efficiently all over the world with minimum risk. Obviously, like anything in life, the person doing the procedure must be well trained and have the experience to handle whatever comes from it. So we tell you to come in on the day, and then on the day of the procedure, you're welcome into the hospital. You would have decided what the things you want. Okay, so there's something called birth plan as well. So birth plan means when I come into hospital, I want my mom to be there. I don't want my mom to be there. I want my husband to come into theater with me. I want to play Christian music. I want to play Burna Boy. I want to do this. Can I bring my music in? Where can I take my pictures from? Who's gonna take my pictures? Can my person, the person that's coming into theater with me, can he help me take my pictures? Oh, do I want to cut the cord? All those things would have been discussed before you actually come into the hospital. So you have a plan and you can share your plan. Obviously, your plan needs to be sensible and it shouldn't affect the workflow of the people doing the surgery. So that's that. I don't know whether you want me to stop there for now or whether you have a leading question. Hello?
Sorry, I was trying to unmute. Thank you, sir. So thank you for that. Now to the actual procedure itself, I think two questions that we often get, two recurring questions will be, the anesthesia given. So a lot of
Yes.
moms are like, yeah, so they ask a lot, oh, what kind of anesthesia is given for a CS? And because people also have a thing about epidural, which is usually given for moms that want to do vaginal delivery. So they're like, a lot of moms have also said that after the anesthesia for a CS, they experience back pain for months, for years, and the likes. So I wanted you to please touch on that. And
Okay.
also, some people also ask questions like, oh, I'm going to do a CS. That means I'm not going to bleed after. So I wanted to touch on those two things.
Okay, so let me go back to, so you get admitted on the day of the surgery. They take you into your room. When they're ready in theater, somebody will take you down, well, whether downstairs on the same floor, and you're coming into theater. You will be coming with your husband, your mom, your friend, whoever you've chosen to come with you. And then you meet they do all their checks, and then you meet the anesthetist. Like I said, okay, so there are two different anesthesia. There's something called epidural. Epidural is for labor pain, although the process is similar, but epidural is for labor pain. With epidural, you put a needle in and then you put a tube into the back, into the spinal cord area, and then so the tube is there throughout your delivery. So it allows you to continue to use painkiller to reduce the pain. Sometimes it reduces it, sometimes it takes all the pain away, sometimes it doesn't work. So spinal is easier because spinal, you use a very smaller needle. It's a one-time injection, and that once it's injected into that space, it can last about 3 hours. So most cesarean will take about 45 minutes. Most, if it's complicated a bit, it might take about 1 hour, 30 minutes. But most cesarean should be done by average between 30 to 60 minutes. Now, yeah, there are people that report back pain after either spinal or anesthesia or epidural. But I started doing cesarean maybe in the late 90s. And to be honest, I haven't seen anybody that have like chronic pain and it's still disturbing them. I think, yes, some people will complain about the pain for a few months. And what I usually tell people is that our bodies are very different. Some people, anything you do with their body just very sensitive and it reacts to things. The question is that what other alternative do you have? A few years ago, they used to deliver people by putting them to sleep. Now, putting people to sleep in pregnancy is extremely dangerous because all your body is swollen, they can't pull the tube properly, and people used to die from that. So doing spinal anesthesia changes all that completely. It takes all the risk away. So the question for me is that if you compare the small risk of having some back pain for a few months and you compare it to the risk of maybe having something wrong, somebody dying after doing a general anesthesia, then a lot of people, I am sure that everybody will always choose spinal and stuff like that. So yeah, some people complain about it, but it's not a major problem, and a lot of people will eventually overcome it. So I think that's the spinal anesthesia. Now, so they give you the anesthesia and then they start the surgery. They finish getting the baby out is the quickest. It takes about 5 minutes. But obviously closing you back, making sure everything is fine, that takes a bit of a time. So that usually takes, the remainder of the time. The average blood loss during a cesarean is about 500 mils. So if you think about, okay, so can of Coke is 330 mils. So if you add another 120 mils to that, that's the average blood loss. So you bleed during a cesarean as well, probably even bleed more than a vaginal delivery. But the same way a vaginal delivery can have a risk called postpartum bleeding, which is postpartum hemorrhage. You can have hemorrhage with cesarean section as well. So when I say average blood loss is 500, some people bleed more than that, and some people can bleed heavily during cesarean. At the same time, some people can have vaginal delivery and bleed a lot as well because their womb is not contracting at the right time. So both of them, you can bleed. It's not the bleeding that's the risk factor for cesarean, really, I think. So I don't know whether that has answered your question. So like I said, you do the cesarean, you close the person, you make sure they're not bleeding, and then you transfer them back to the room. Most people will, it depends on where you are as well. If you are in most developed countries, you have your cesarean in the morning, you're starting to eat on the same day. I've had this issue with some of my colleagues, and they're very reluctant to let their patients eat in the same day in Nigeria. And I've asked why, because I think the problem is that they're worried about people going to eat eba and amala immediately after their surgery when their bowel have not started. Sometimes as people, we take funny risk. So after your surgery, maybe a few hours after that, you can eat things like toast, tea, maybe even ogi, but not eba, amala, egusi, chicken, not until maybe the next day when your bowel is working properly. So now they keep you on the bed. You have a catheter during the cesarean. Once the anesthesia start wearing out of your leg, and once you can start working, usually maybe later in the day that day or the next day, the catheter comes out, which allows you to go to the bathroom. And a lot of people will stop all the fluids that you're being given and let you be. In most part of the world as well, they will discharge you second day of your cesarean. In Nigeria, we still keep people for maybe 3 days, 4 days. Maybe because of the peculiarity of Nigeria, really, we don't have a very strong emergency service. So you want to keep people in the hospital and make sure they're absolutely okay before they go home. Sometimes your baby can keep you in the hospital as well because they check jaundice a few days after the baby is born. And if your baby has a high bilirubin, they want to start managing it after. So, yeah, I think part of the cesarean part as well is giving you an injection called heparin, which reduces blood clots in your legs, which is very associated with cesarean section. So I think that absolutely answered most of your two questions as well.
Yes, sir, you did. Mamas, please start dropping your questions in the chat box. Start dropping your questions. I'm going to ask just one or two more questions. Let's have your questions and your concerns now in the chat box. As I want to talk about, I know you've touched a bit about it, but I want to talk about the recovery. Even as much as 3 weeks postpartum, 4 weeks postpartum, a lot of moms are asking, can I take milk as a CS mom? Can I take pepper soup as a CS mom? Can I take... You are not in a bondage.
No, you're not in a bondage.
consent.
You can take that. You can take that like the next day after your cesarean. There's no restriction. There's no. So once your doctor says, "Oh, your bowel is fine," you can. I think one of the problem, and I can see it. Honestly, I can see them, is that there's a lot of, in most part of the world, they just let you get on with your life after your cesarean. But I don't know whether it's an experience thing. But in Nigeria, there's a lot of, don't eat this, don't eat that. But it's not true. You can eat anything you want after your doctors have confirmed that your bowel is working well, which is usually after 24 hours. You can eat anything you want, anything. So I think that is very important. Okay.
All right. All right. Thank you, sir.
Okay,
So
okay. Let me talk about the recovery one as well. You mentioned
yes.
the recovery. So you go home. By the time you're going home, obviously you've just had major surgery, so you'll still be sore. Most hospitals use no dissolvable suture, so you don't have to come back to hospital to remove your stitch. Also depends on where you are and what they do there. So by the time so your recovery, I think one of the challenges with cesarean is that you have a tummy cut, you're trying to heal, you have a baby. So I think it's important that you have support as well, whether it's your mom, whether it's your sister, whether it's house help, to help you in that process until you are okay, because it can be a bad experience if you don't have support, because you can, but you have to have a very supportive husband as well. Your husband must be able to be active during that period, because you're not, remember, so it's like two in one. You have a surgery, you have a baby. Both of them are major stuff, but you now combine the two. So you have to have somebody that is supportive there. So, okay, so you get home, you start recovering from your surgery, but you're also looking after your baby. And so I think it's important. I mean, the Igbos call that is it omogo? Is it omogo or omo? But the Yorubas call it, your mother-in-law is coming to help and stuff like that. So somebody must be there to help you. And it's good for the person to have experience as well. So now you recover a lot. So a lot of the time, it takes about 6 weeks for you to have complete recovery, because it's the same. Like I said, it's not about the baby, it's about you, that you've just had a surgery. So most people will be fine after 2 weeks, but complete recovery takes time. And you've got to remember that there's no need to that's why they will tell you not to drive a car until about 4 weeks, because your body is not completely healed. You may not be able to press your brake properly during an emergency stop and stuff like that. So that's I don't know whether that answers the question. Yeah, that's it.
All right. I can see we have questions on the chat. I think my final question to you, just before we get into the chat box, will be, for emergency CS, is there anything that the mom should know? So, I mean, they've concluded they're going to have a vaginal delivery.
Yeah.
Maybe labor is not progressing as it should. They are, they're not then told that they need to have a CS. Is there anything that they should know to also help them make a decision? Because we had a case recently of a mom in our community whose her partner and I think in-laws told her while she was in labor to carry her bag and start going to register in another hospital. It was such an interesting case to see. So just to ask, what should moms know when it comes to an emergency CS, making that decision? Also, because some hospitals have been known to propose a CS when there is no need for a CS, perhaps for financial reasons. We can't confirm.
Well, I think the first thing is that, why are you in such a hospital? Why are you in a hospital where you're saying somebody's proposing a CS for financial reason? I mean, so the first thing I want to believe is that a lot of people have brain and they should be able to make sensible decisions. So, why will the doctor? I mean, the first thing is that none of my colleagues will want to do a cesarean because they need the money. They might want to do a cesarean because it's convenient for everyone. That's different. But doing a cesarean for monetary reason, I don't think. Now, I want to believe that you would have gone to a good hospital. So your assessment of your hospital that you're going to deliver on start from day one. So if you're not comfortable and you feel that they're into money, I mean, some people have been accused before of wanting money. So people's emotions sometimes cloud their judgment, and people say unfair things to professionals sometimes when they are upset or angry. So the first thing is that there are 3 categories of emergency cesarean section. So we call it Category 1, Category 2, and Category 3. Category 1 means you have to deliver that baby within 30 minutes, or that baby, you will lose that baby or lose the mom. All right, so that's Category 1. So when I tell you you need a Category 1 cesarean and you don't want to do it, I will tell you that it's your choice because you can die from it. There's no other way to say it to people. It's either you can die or the baby will die. You know, sometimes when we make, it's not that we want to, we're not happy to make this decision, but we see the evidence right in front of us and we have to call it. Now, I want to believe that you will be having your baby under a well-experienced person as well, which you trust totally. By the time somebody is telling you you need a cesarean and you're doubting them, then there's a problem, because why are you in a position where you're doubting your doctor in the first place? So, and also, I think a lot of people need to change their mindset. I think one of the major problems why people get into problem in Nigeria sometimes is doubting your doctor when your doctor tells you you need something. I'm talking about the good hospital. Nigeria has a lot of different space, but I'm talking about the good hospital. I've seen people that their doctor told them they need cesarean and they did not heed the advice and their baby died. I've seen that. All right. I've seen people where the wife needs cesarean and the husband is saying no, he's not going to have cesarean, and eventually the woman died. The man is going to marry another woman. So when somebody that you trust and you've been looking after you tell you something professionally, you've got to listen to them. Now, if, like I said, if you don't trust your doctor from day one, move to another hospital where you can trust your doctor. That is not the time to be doubting anybody at all. That, oh, maybe they need money, maybe they need that. Please don't do that. Make decisions, go to the right hospital from day one, and then make the right decision. And if they advise you, please follow advice. Now, so that's Category 1. Category 2 is, oh, madam, you need a cesarean. Maybe you're not making progress and stuff. That's Category 2. Oh, well, the doctor is doing something next door, but he's coming. The doctor is doing something next door, but he's coming. So, but we can start preparing for the cesarean section. That can be delivered within, by 60 minutes to 1 hour or 2 hours. Because there's no distress. The woman is not in distress. Sorry, from Category 1 as well. Let's say the woman is bleeding or the baby's heartbeat is dropping and stuff like that. So for Category 2, it's like, okay, this woman has not made progress. Let's do a cesarean, but we're taking our time. Category 3 is, okay, madam, I know you want a vaginal delivery, but unfortunately, we've picked something up. We're going to admit you, but we're going to do your cesarean tomorrow. That means it's not an emergency, but something has come up that has changed your preference from having a vaginal delivery to a CS. But like I said, I think somebody put it here, doctors need to educate, enlighten. Now, I see, a lot of us in Nigeria were graduates. Enlighten yourself as well. If your hospital is not doing much, I want to believe that when you get pregnant, you read as much book as possible. You look at, you have 40 weeks from when you got, or maybe, when you got pregnant to when you're delivering. You can enlighten, you can read about cesarean section, read about the reason. Don't wait for, yes, doctors run, our hospital run antenatal classes and stuff like that. But also, it's your body as well. You need to do something about it as well. You need to read about it as well. Now, it's a very awkward position for a doctor or for somebody to be saying, oh, you need a cesarean, and somebody saying, no, I don't need a cesarean. It creates that can happen. It can happen in as much as it happens a lot in Nigeria. It happens in England, America as well. But but people make decisions about their life and then make that decision, whether it eventually leads to a good outcome or a bad outcome. You take ownership of it. See, if I offer you a cesarean
Can't see
and you say
anything.
Hello, can you hear me? Please, can you tell whether you can hear me?
Yes,
please?
sir. We can hear you.
Well, somebody is saying I can't hear anything.
We can hear you
We can
clearly.
hear. Maybe it's her network.
Okay, we can
Well,
hear
can
you
you?
now.
Yeah,
We can
please.
hear
Can
you.
can you mute yourself, please, so that it doesn't? Can everybody mute themselves, please? All right. So as I was saying, I think the onus is you. I mean, one, you're an adult. Two, if I tell you you need cesarean and then you're saying I shouldn't do it and I go and do it, that's grievous bodily harm. I've assaulted you. You can sue me and they can arrest me. So if I tell you you need a cesarean and you say you don't want it, then I'm going to just step back a bit, tell you the risk, document it, and then keep on looking after you. So whatever the outcome, as long as I know that you are in your right senses when you are making that decision. So I cannot force you to do it, but also just remember that you have a child and yourself to look after and I think contrary to people's opinion, let me give you about a few years ago, I was in training. There was a survey done on female medical doctors. They asked them that what will be their preferred their preferred delivery option. Almost 80% of them say they will have cesarean section. Now, also, I think from the religious aspect of Nigeria as well, people go to funny churches where they tell them you have to be a virtuous woman, you have to be, what's that? There's a particular word they use. Please, can somebody explain? Can somebody maybe, there's one particular word they use for people
Hebrew woman.
Let's Hebrew woman. Please, without any doubt, I'm a Christian. But just leave Hebrew woman alone. Please be a Nigerian modern woman and make your right decision at the right time. Okay? That's very important. Don't be doing Hebrew woman. Even if Hebrew woman comes now and there's cesarean section, trust me, Hebrew woman will have cesarean section when it's necessary. So I think sometime as well, unfortunately, our religious institution doesn't help as well. And, but I think in my church, I remember my pastor saying, if you need cesarean, please go for it. Don't be making stupid decision about X, Y, Z. So I think some people, no matter how you make them aware, they've made up their mind, because unfortunately in our society as well, some uneducated people make women feel as if having vaginal delivery or having CS is abnormal. There's nothing abnormal about cesarean section. It's a type of vaginal, is a type of delivery, and it should be encouraged. If you need it, please have it. Okay. All right. So there's some questions that I know there's somebody Olayinka who says, is it okay to have a planned cesarean section at 38 plus 4? Yes, it depends on the reason why they want to do that cesarean at that time. But yeah, it's okay. The only thing is that the recommendation in most modern societies that if you're doing a cesarean less than 39 weeks, give something called steroid. The reason they explain that is that, okay, so when you have a vaginal delivery, the baby is going through a space. And then when it's going through that space, the fluid in that baby's lung is squeezed out. So that those babies usually don't have any problem with breathing. But if somebody is going through cesarean, because they're not going through that tunnel or that passage, they still have a lot of fluid in their chest and they get admitted to neonatal care. And they've done a few research and they noticed that it's very common when it's done when cesarean section are done under 39 weeks. So in most either UK hospital, US hospital, if they're going to do cesarean before 39 weeks, they will give you steroid. I'm not saying that you can't do it. I'm not saying you can't do cesarean below 39 weeks because it depends on the reason. But your doctor needs to think about either giving steroid or if there's no problem waiting till 39 weeks. So the second question, doctor, do you mean if your baby is too small, it might call for CS? Yeah, absolutely. If your baby is very small, your doctor might say, okay, you know what, I think it's safer to do cesarean so that the labor process doesn't stress the baby out. Korede, my first pregnancy, I had an elective CS. I'm pregnant with my second and is multiple. I did a first scan and the report showed viable to his sciences with gestational cell. my next doctor's appointment, I was asked to do another scan, and the sonographer said he couldn't see the divider. He needed to know the position. I did another scan and report. So the placenta is posterior. Both babies share one placenta and one sac, meaning they are identical. On my next visit, I presented my scan. I was told it's high risk. I believe it. Well, yeah, there are different type of twins. You can be a twin, you can have different twins. You can have twins that are totally in one bag. That means both babies, there's no separation. It's very common. It's called monochorionic monozygotic twin. It's very uncommon, okay? But you can also have most twins they can share the same placenta, but in different bags. So let me explain the reason. If you share the same bag, that means two babies are in one bag. And it means that they can move freely. And sometimes they can move around their cord. Just remember that you have one baby attached to a placenta, same placenta, and another one attached to the same placenta, and they're moving. So their cord can entangle, and that can be dangerous. So nowadays, if you have that, you're meant to be managed in a high-risk hospital where you're getting scanned regularly for any issues. And then, yes, for such babies, to reduce that entanglement or something going wrong, they deliver such twins about 34 weeks. Now, I don't know the details of your scan. I don't know the detail. I will say that get a good scan, get a good doctor to look at it and make sure that you are offered the right treatment. But I think, yeah, you have to trust your doctor to make the right decision. What is the risk factor of giving you an induction for small baby to come out? Well, if your doctor induce you for small baby, it means that they believe that they can still deliver you vaginally. But the reason a lot of people will offer UCS for small babies is that small babies don't cope well with labor. So they start inducing you. Every contraction is stressing the baby out. Yeah, I'm not saying that you can't get a vaginal delivery through an induction with small baby, but the risk of it becoming an emergency is a bit higher than normal. So I think, yeah, I hope I've answered that. What caused baby to, I think the regular heartbeat is totally different. There's so many, so I'm not going to go into that. So let's just stay within what we're talking about today, which is planned cesarean. Okay, I don't know whether I think, is there any other question?
Yes. Okay, this person is talking about educating. I think we've talked about that. Just as I was giving an example, imagine my shock, sir, when a mom that has been through our program, has been educated, was sending us a message in the labor room that her partner said she should pack her things and in-law somewhere, said another hospital. I was very shocked because we've done sessions on picking the right hospital. We've done sessions on what to expect, differences of labor. So I wonder that if an educated person can be saying. So I think that mothers also have a responsibility to yourself and to your child
And
to educate yourself.
I think very important. So I'm not saying this because I want disharmony in your house, okay? The first thing is make sure you choose the right hospital. Make sure you choose the right doctor. It's extremely stressful for you to be looking for a doctor last minute because you're changing your mind. Very stressful, not only for you, for your baby as well. For you to be in labor and be looking for another hospital, it means that somebody has not done their due diligence. Now, the first thing is also for women, please, make the right decision, but also know that at the time, it's your body as well, okay? So please you have to find a way to communicate with your partner and not let anger or anything make a wrong. Why would you want to be leaving a hospital when you're in labor to go to another place? It's so stressful. It's so, the risk is so high and stuff like that. So, and again, please make your research before you even get to the point where you are about to deliver. If you don't like your hospital for any reason, please go and look for a second opinion somewhere way before the delivery time. But don't be educate your, you must have reached, I mean, did you not go to antenatal class? Did they not talk about cesarean section there? Do you not, nowadays you can get any information or any video to learn about anything on YouTube. So you need to educate yourself as well. You need to a lot. I mean, in my practice, which in the MVI, I want to believe that almost everybody that comes there are graduates of a so or even have gone through secondary school. That just leave graduates, secondary school. You should be able to know what is right for yourself and what is right for what's not right for you. So you have to be intentional about your delivery as well, especially in a country where standard of medical practice is different in different hospitals. So you have to be intentional. You have to have made the right decision, do all your research, and then go to where it's safe for you to have your delivery. And then once you make that decision, please don't get into a position where you're arguing with your doctor. My doctor said I need CS. Maybe they want to collect money. How much is the money you're bringing? How much? That somebody will be lying to you that you want to do cesarean and stuff like that. Now, the reason the doctor wants to do the cesarean may not be obvious to you, but it might not necessarily be that they're lying to get your money. If you're in a good hospital, a doctor will not be lying to you. Now, the other thing as well is that, so for a vaginal delivery to happen, the doctor must be there, the patient must be there, the hospital must be there. I've seen patients come and say, my husband is going to be away for XYZ, and I want him to be around. Can we have our cesarean at so time? The same thing, a doctor might say, I'm gonna be on holiday from next week. I know you're not due for your cesarean till next week, but can we do it this week? But it's up to him to now make sure that everything is safe for you to be able to have that baby safely. So I want to believe that the relationship between a doctor and a patient must be extremely professional, but extremely transparent for you to make your decisions. All right.
Thank you very much. Thank you, sir. And I mean, when you talked about this, what your final the final words you shared, I know that's one thing that you have at South Shore. I remember when we had this was way back when we had the fibroid conference at Access Bank. I think that was about 4 or 5 years ago. And I remember when your patients were sharing their testimony, even Toke Makinwa. I remember they were talking about the care that you offer and how transparent you are with them, and that just reminded me. So well done on the great work that you are doing. We also have moms that use South Shore. We have quite a number of moms that have used and are using South Shore. So mamas as well, please, if you are in VI area, there's also another one in Ikeja. You can check out South Shore. They also have a hospital for mamas that are trying to have a baby. So if you have anybody that is trying to have a baby, you can definitely please check out Ikeja. I've known Dr. Alabi for sir from way back. We can see your face now. From way back, I think 2017 or so years, and follow the work we've done. We have had you on my radio show back then. I mean, just so much work that we've done together. So mamas, please, and just again, to as Dr. Alabi has said, it's not about your money. So it's not about your money. In fact, this hospital that the mama had said, I'm not going to mention, but it's one of the best hospitals as well in Nigeria. So I was like, I really doubt that that's the situation that you want to use to pack your bag in the middle of labor to another hospital. No. It's really not. So please also educate yourself and educate your partners. The number of messages we are getting about my partner said this, my partner said that is alarming. Is very alarming. Please educate your partners. Thank you. So I don't know if you have final words.
Yeah, I think my final word is that, see, without any doubt, please always encourage your partners are supportive, they're there. But I think at the time of delivery, sometimes people feel that they're not in control, but they want to be in control. You cannot be in control because the professionals are there. And and you're not an expert in calling whether a woman is in distress or the baby is in distress or whatever. So when you're in labor, please, you have to. It's one of those things. It's like saying that you don't trust you're in a plane, but you don't trust your pilot. You want to get down. and the plane is. So please try to do as much research as possible about, one, your doctor, two, where you're delivering, and make sure that you have had a very constructive discussion before you even get to delivery. And then when you're in labor, if they advise you XYZ, please. And again, I think one of the challenges as well is that some people will be in labor and then they'll be calling their brothers or sister in US, and then those ones, or a doctor in US, and you'll be advising. I think all that just creates unnecessary drama, really. By the time you're getting into labor and you have totally put your faith in the hospital, please just support them. Now, I'm not saying that maybe after delivery you think that things are not going to plan. Yeah, you can seek second opinion anywhere. But I think it's very, very important that you have done your research before you go for your delivery. And please, always be amicable in your approach. Let your partner go with you for antenatal classes if possible. Let your partner go with you and see the doctor. Don't let your partner come in at the end. And sometimes men's ego sometimes play a part in all this decision making. Oh, why am I not helping? Why am I not the one making this decision? So most importantly, what I'm going to say is that please be safe. Be safe with your baby. Remember that as a pregnant woman, you are the one carrying the baby. And if anything happens to you, unfortunately, people will mourn 2 years, 3 years, 4 years, 5 years, 6 years. But remember that you cannot be pulled back from whatever happened. Or even if you lose the baby as well, it can, that decision is going to stay with you forever. It's going to stay with you forever. You might have 1 or 2 more after, it doesn't matter. So it's always important to make the right call. Always try to make the right call. Thank you.
All right, then. Thank you so much. And recovery, we've talked about it. The recording will be provided, so you can always listen back over and over and over again. On that note, I want to thank you, sir, for your time. We're so privileged to always have you here, and just really to have a relationship with you. We're just so privileged. Thank you very much again.
Thank you very much.
Dr. Alabi's first years was in the 90s. So you can imagine when in the 90s they just gave birth to someone.
You can imagine that how many I would have done. Yeah.
All right.
Okay.
Thank you,
all right. Bye-bye. All right.
Thank you so much, doctor.
Thank you.